Hello, I'm Manoj Karmakar. If you haven't registered or subscribed to this channel as yet, do remember to subscribe so that you can get regular notifications of any future uploads. In this next video, I'm going to be discussing with you a sequential ultrasound imaging technique to image the individual elements of the brachial plexus above the clavicle and its role in clinical practice. Enjoy. I'd like to take this opportunity to thank the organizers for inviting me to speak at this meeting. Also, before I begin, I'd like to declare that I have no conflict of interest whatsoever relating to my presentation. The objective of my talk is to describe a sequential ultrasound imaging technique that goes by the acronym SUIT that would facilitate accurate identification of the individual elements of the brachial plexus before the performance of a brachial plexus block, and discuss some of the potential advantages of using a sequential ultrasound imaging technique. The brachial plexus is made up of the roots, trunks, division, and the cords. There are 5 roots that make up the brachial plexus, which are from C5, 6, 7, 8, and T1. You can see here they are the C5, 6, 7, 8, and T1. These are the ventral rami of the cervical nerve roots. So when we say roots, these are the ventral ramus of the brachial plexus, and they are not the cervical nerve roots. They are indeed the ventral ramus of the cervical nerve roots. The ventral ramus of C5 and 6 join to form the superior trunk. The C7 ventral ramus continues as the middle trunk, and the C8 and T1 fuse to form the inferior trunk. The 3 trunks then divide into an anterior and a posterior divisions, which then come together to form the 3 cords of the brachial plexus. Since we are discussing above the clavicle, we're going to restrict ourselves to identification of the individual ventral rami, the individual trunks, and maybe some of the divisions of the superior, middle, and the middle trunk. The use of ultrasound for brachial plexus blockade was first described by Stephen Capral in 1994. It's about 27 years ago. They used 2D ultrasound for supraclavicular brachial plexus block. Brachial plexus sonography literature in the radiology literature only appeared in 1998, 4 years later. When you perform an interscalene brachial plexus block, you identify the C5 and 6 ventral rami, and the local anesthetic is injected close to the ventral roots of the brachial plexus, i.e. the C5 and 6 ventral rami. During a supraclavicular brachial plexus block, you identify the trunks and divisions of the brachial plexus of the supraclavicular fossa. During an infraclavicular brachial plexus block, you target the cords of the brachial plexus below the clavicle, and there are different approaches to this. And during an axillary block, brachial plexus block, you target the terminal branches of the brachial plexus at the axilla. So during an interscalene brachial plexus block, a transverse oblique ultrasound scan is performed at the neck, where you identify the elements of the brachial plexus between the scalenus anterior and the scalenus medius in the interscalene groove. These elements within the brachial plexus are the roots of the brachial plexus and have often been likened to a stoplight sign, where the 3 lights resemble or represent the ventral ramus of C5, 6, and 7. The needle is inserted in plane from a lateral to medial direction through the scalenus medius muscle so that it's in a periplexus location, where the local anesthetic is injected and then used for shoulder surgery. But the question is, how accurate are we in identifying the individual elements of the brachial plexus that we are often forming our local anesthetic injections? Let's take a look at the literature. Stephen Capral, indeed, in 1994, in this classic publication documents that he was able to demonstrate the C5 to T1. That means all the ventral ramus of the brachial plexus was seen in a single interscalene groove image in 1994. Jose Andres and Xavi Salablanche reported that the elements within the interscalene groove are indeed the trunks of the brachial plexus. They are not the roots of the brachial plexus. More recently, Dr. Perles and Dr. Chan and a group from Toronto have labeled this more conservatively and more cautiously as probably the roots and probably the trunks or divisions of the brachial plexus at the interscalene and supraclavicular fossa respectively. Peter Marhofer and William Harold Griffith and their colleagues were labeled the C5, 6, and 7 within a single transverse oblique scan of in the interscalene groove and labeled them as nerve roots. There are also several editorials that have been published that highlight the inaccuracies in labeling of the various brachial plexus elements within the anesthesiology literature. They've often described that there is a need to reevaluate the stoplight sign because they are not always the C5, 6, and 7 ventral ramus. It is with this objective that Dr. Carlo Franco and Dr. Williams performed this cadaver study in which they investigated, or they performed cadaver dissections to evaluate what really made up the three lights of the stoplight. In their cadaver dissection, they consistently found that the C5 root was significantly smaller than the C6 and 7. They also found that C6 and C7 ventral rami often presented macroscopic evidence of intra-root splitting. What does it mean? As you can see here in this very clear-cut dissection by Dr. Franco and his colleagues, you can see here C5 ventral ramus is the smallest of the 5 ventral rami of the brachial plexus. He also demonstrated that the C6 and C6 often exhibits features of intra-root splitting. That means the C6 and C7 will often exhibit features of intra-root splitting, like you see in these images here. So therefore, they go on to conclude that the stoplight sign actually has 3 lights, but actually they are only made up of 2 nerves. This has clinical significance because if you misidentify the 2 elements of the C6 as C6 and 7 and you place your needle between the 2 elements of the C6, that would amount to an intraneural injection and may result in devastating neurological sequelae postoperatively. Therefore, it's desirable for safety and accuracy to accurately identify the individual elements of the brachial plexus during a brachial plexus block. When you perform brachial plexus sonography, there are a number of key anatomical landmarks, i.e. anatomical landmarks that have very typical sonomorphological features. One of them is the C7 transverse process. As you can see here, the C7 transverse process has only a single posterior tubercle. The anterior tubercle is either rudimentary or is missing. The C6, which is the contiguous transverse process above the C7, has a very prominent anterior tubercle. This is also referred to as the Chesniak's tubercle. So once you identify the C7 transverse process, it's easy to then locate the C7 ventral ramus and the C6 ventral ramus contiguous to that. Also, another anatomical landmark in the brachial plexus highway is the spar of the brachial plexus that was described by Dr. Hanna, a neurosurgeon. Traditionally, when you look at the anatomy of the brachial plexus, it's often described that the superior trunk divides into a suprascapular nerve and then gives off an anterior and a posterior division. However, in this trifurcation is where Dr. Hanna, in his cadaver dissections, demonstrated that the anatomical arrangement was not an SAP arrangement. In fact, he single-handedly performed these cadaver dissection and challenged what was described in the early 1400s by Vesalius. He challenged this anatomical dictum, saying that the arrangement is not SAP, it's usually in the form of a suprascapular nerve, followed by the posterior division of the superior trunk, and then the anterior division of the superior trunk. So Hanna goes on to describe this as the spar of the brachial plexus. More recent publications on the brachial plexus actually represent it as the suprascapular nerve from a lateral to medial direction, followed by the posterior and then the anterior division of the superior trunk. So this is what is often referred to as the spar of the brachial plexus. Also, another important neural arrangement in this brachial plexus highway is the neural stack formed by the superior trunk, the middle trunk, and the C8 between the two scalene muscles and overlying the transverse process of T1 and the first rib complex. As you can see here, the C5 and 6 have fused to form the superior trunk, and the C7 continues as the middle trunk, and the C8 is now lying on top of the T1 transverse process and first rib complex. So this neural stack that you see is very consistent from individual to individual. So what lessons have we learned so far with brachial plexus sonography? We've learned that the C5 is the smallest of the three roots between C5, 6, and 7. The C6 and C7 exhibit intra-root splitting, which is usually macroscopic but can also be identified using ultrasound. The stoplight sign that's often used in the brachial plexus sonography literature in regional anesthesia are actually made up of only two nerves. The C7 and C6 transverse process exhibit unique sonomorphological features. The spar of the brachial plexus is where the trifurcation of the superior trunk occurs, and the arrangement of the suprascapular nerve posterior anterior division are very consistently identified in most individuals. The C8 ventral ramus lies on top of the T1 transverse process and the rib complex that I demonstrated to you. The T1 ventral ramus and the C8 are more difficult to visualize, particularly the inferior trunk is more difficult to visualize, but nevertheless, with the technique that I will be demonstrating to you, you'll hopefully be able to identify this in about 40% of individuals. So what is the sequential ultrasound imaging technique? The sequential ultrasound imaging technique goes by the acronym SUIT, S-U-I-T. It's a transverse oblique scan sequence that we start from the supraclavicular fossa, and then we progressively sweep the transducer in a cephalad direction through 7 contiguous sites, and during this process you are able to identify the individual elements of the brachial plexus. Starting from the supraclavicular fossa, you then sweep it to identify the C7 transverse process and the C7 ventral ramus, thereafter the contiguous C6 transverse process and C6 ventral ramus, and then the C5. And once you've identified the C5, the transducer is now manipulated or translated in a caudal direction to see the fusion of the C5 and C6 to form the upper trunk. It's also often referred to as the Erb's point, where the C5 and 6 fuse to form the upper trunk. And as I alluded to before, the neural stack formed by the superior, middle, and the C8 nerve ventral ramus on top of the T1 transverse process and first rib complex, and thereafter identify the formation of the inferior trunk at the supraclavicular fossa. So the transverse oblique scan starts from the supraclavicular fossa. You can see here we're using a high frequency linear transducer that is gradually swept in a sweeping motion from the supraclavicular fossa all the way up to the C5 ventral ramus transverse process, and then it's swept back again in a caudal direction with a gradually increasing angle until you get back again once to the supraclavicular fossa. During this sweeping motion, at the supraclavicular fossa, you can identify the trunks and divisions of the brachial plexus as they are located posterior and lateral to the subclavian artery and often deep to the omohyoid muscle, as you can see here. Next, when you sweep the transducer further cephalad, one can identify the C7 transverse process by its very typical sonomorphology of having a single prominent posterior tubercle. You can see here, this is even more prominent. You can see here the C7 transverse posterior tubercle, and anterior to that lies the C7 ventral ramus. And thereby you can see the ventral ramus that's in the interscalene groove between the scalenus anterior and medius. Cephalad to that is the C6 ventral ramus. So the C7 ventral ramus is located anterior to the C7 transverse process, and adjacent to that is the vertebral artery and the vertebral vein in that exposed area. So therefore, everything that looks hypoechoic or anechoic and round to oval next to the C7 transverse process is not a nerve. You have the vertebral artery and the vertebral veins that are located next to it. If you sweep the transducer further cephalad from the C7, you can now identify the C6 transverse process by its very prominent anterior tubercle, the Chesniak's tubercle, and a much smaller posterior tubercle. In between lies the C6 ventral ramus as it emerges from the intervertebral foramina. Cephalad to that in the interscalene groove is the much smaller C5 ventral ramus. As you can see here in this video loop, the C6 is a very prominent anterior tubercle. The posterior tubercle is much smaller. The C6 ventral ramus is lying in between the two tubercles, and the cephalad to that is the much smaller C5 ventral ramus. So the C5 ventral ramus is a much smaller nerve when compared to the C6 and C7. Also, you can see here the typical sonomorphology of the C7 and the C6. The C5 ventral ramus is a much smaller nerve, and as it emerges from the intervertebral foramina, it can be clearly identified between the two tubercles. As you can see in this video loop, it's just emerging from the intervertebral foramina, and it lies between the anterior and the posterior tubercles of the C5 transverse process, a much smaller nerve. Once you've identified the C7, if you sweep the transducer cephalad, you can see the C6, very prominent anterior tubercle, and a much smaller C5. I think it's also important to understand that these ventral ramus may exhibit splitting of these nerves, as been referred to in the literature, and I had alluded to previously in one of the cadaver studies by Dr. Franco. So when you scan these nerves in the interscalene groove and you dynamically scan them proximally and distally, you can see here that this is indeed the C6 ventral ramus that is now exhibiting intra-root splitting. So you can see there are three, but actually this is C5 and the two components of the C6 ventral ramus. This is another image where you can see the C5 and C6 and C7. You can see the C7 is now splitting into two parts here. They are the two parts of the ventral ramus of the C7. In fact, in this individual, you can see this is the C7, which shows splitting. The C6 also exhibits splitting, and the C5 is a much smaller nerve. So you can see here that there is actually 5 neural elements: the C5, C6, C6, C7, and C7. So it can be very easily misinterpreted as C5, 6, 7, 8, and T1. Once you have identified the C5 transverse process and the C5 nerve root, ventral ramus, it is now important to focus your attention on what the C5 ventral ramus does in terms of how it fuses with the C6 to form the superior trunk. And therefore you see this superior trunk sequence in this video. You can see here, you see the C7 here. Now you see the C5 and C6. The C5 and C6 fuse to form the superior trunk, which is more clearly visual here. You can see the C5 and C6 fuse to form the superior trunk. The middle trunk is continues as the C7. And if you focus your attention now only on the superior trunk, you will see it forms three divisions here. You have the suprascapular nerve, the posterior division, and the anterior division. So this essentially forms the spar of the brachial plexus. So you have a suprascapular nerve, the posterior division, and the anterior division. And just caudal to that is the middle trunk and the C8, which is now lying on top of the apex of the lung here. It's also important to draw attention that the transverse cervical artery is very closely related to the superior trunk. It often crosses the interscalene groove anteriorly, lying on top of the scalenus anterior and the medius muscle. On certain occasions, it may also intersect it may go through the scalenus, the interscalene groove between the superior trunk and the middle trunk. Next is, after you've identified the superior trunk, then it's time to identify the middle trunk and the C8 ventral ramus neural stack. So this neural stack is very clearly identified because the C8 lies on top of the T1 transverse process and the first rib complex. So once you can see here that the superior trunk is a much larger nerve, you can see here, the middle trunk lies just caudal to the superior trunk, and the C8 is the isolated nerve, ventral ramus, here on top of the T1 transverse process and the first rib complex. Once you have identified the neural stack formed by the superior trunk, the middle trunk, and the C8 ventral ramus, we now will try and identify the formation of the inferior trunk, i.e. the fusion of the C8 with the T1. As we know, the C8 ventral ramus lies on top of the T1 transverse process and the first rib complex. It fuses with the T1 that comes from underneath the first rib and fuses with the C8 ventral ramus on top of the first rib further down. So when you perform a scan, as I showed you the neural stack, you are visualizing the superior trunk, the middle trunk, and the C8 on top of this bony complex. This is also seen very clearly in this cadaver dissection by Dr. Zhu and his colleagues. You can see here the C8 is lying on top of the bony complex. The T1 comes from underneath and fuses to form the inferior trunk in relation to the corner pocket. So the formation of the inferior trunk can be clearly demonstrated, and we have described this in our recent publication in Regional Anesthesia Pain Medicine. As you can see, if you imagine that the red pain is the pain that gives you the neural stack, if you now sweep the transducer with a slightly tilting motion like so, if you now pan the transducer from a cranial to a caudal direction like so, you will now be able to see the fusion of the T1 with the C8. You can see here the C8 is lying on top of the first rib. The T1 is now coming from underneath. It swings across and then fuses with the C8. You can see here the T1 is coming from underneath. It swings around and comes to fuse with the C8 to form the inferior trunk at the corner pocket. So the C8 joins the T1 to form the inferior trunk at the corner pocket. So based on the sequential ultrasound imaging technique that I have demonstrated to you, I think it's fair to say we can very accurately identify the ventral ramus of C5, C6, C7, C8, and T1. You can also accurately locate the fusion of the C5 and 6 to form the superior trunk, the middle trunk, which is the continuation of the C7, and the inferior trunk, which is the fusion of the C8 with the T1 ventral ramus. I've also shown you that the superior trunk often trifurcates into a spar, which is the suprascapular nerve, the posterior and anterior division. You may also see in some individual the divisions of the middle trunk into into its anterior and a posterior division. It's more difficult to define the divisions of the inferior trunk because this often takes place, I think, behind the clavicle. In a recent publication, we've also demonstrated that SUIT is a reliable technique. You can accurately identify majority of the ventral of the neural elements, particularly the C5 ventral ramus, the C6, C7, and the C8 ventral ramus, including the superior trunk, the middle trunk, and suprascapular nerve in 80 to 100% of individuals. The T1 and the inferior trunk are more difficult to identify, but even these elements are seen in about 40 and 60% of individuals respectively, as we did in this cohort of volunteer scans. We've also demonstrated that SUIT is a reliable technique in identifying these individual elements. It produces a very high inter-rater agreement when identifying the superficial elements, particularly the C5, 6, and superior trunk, is almost perfect with a kappa of 1. For the other elements, it's usually moderate to fair. This is not bad given that this is a new technique and we are all getting familiar with it, and I'm confident with time we'll only get better at identifying these various elements. So now the question that may be going through your mind is, why use SUIT? First of all, take a look at this video. In this you can see the anomalous position of the C5 ventral ramus. You can see here, this is the C6, and you can see the C5 is actually located anterior on the anterior surface of the scalenus anterior muscle. In fact, it's not within the interscalene groove at this level, and in fact you can see the C7, C6, and the C7 here. So the C5 usually comes quite caudally before it fuses with the C6 to form the superior trunk. So that is an anomalous location of the C5 ventral ramus. This is another situation where you can see the C5 ventral ramus in a small muscular compartment within the scalenus anterior muscle. It's totally separate from the other elements. It's only when it goes further down that it fuses with the C6 to form the superior trunk. We've also demonstrated that the T1 may not fuse with the C8 at the supraclavicular fossa. As you will see here in the sequence of images from left to right, you can see that this is the C7 based on the sonomorphology of the C7, so 6 and 5. You can see the neural stack formed by the superior trunk, middle trunk, and the ventral ramus. Also note there are many muscular bridges between these various neural elements within the interscalene groove. These are not often referred to in our region anesthesia literature, although it is very well known in anatomical literature. You can now see that the C8 is located on top of this osseous complex, and the T1 is coming from underneath, and normally it would, as I showed you before, it would fuse to form the inferior trunk in the corner pocket. But in this individual, as you see here, as we track it, you can see that the C8 remains isolated in the corner pocket, but the T1 now has gone medial to the subclavian artery and between the subclavian artery and the vein in an anomalous position on top of the first rib and in between the subclavian artery and the vein. This poses a challenge because if you are to perform a brachial plexus in this individual, supraclavicular brachial plexus block, then this connective tissue element barrier that is interposed between the T1 ventral ramus and the C8 may lead to inferior trunk sparing. As you can see here, we perform the injection at the corner pocket, and then we breach this connective tissue layer to inject selectively the T1, which was located medial to the subclavian artery. So this connective tissue barriers have been described as the costopleural membranes. These are the costopleural ligaments, and they are often described as Zuckerlander-Sebelius ligament, and they are about 5 or 6 of them that may sometimes interfere with the T1 actually reaching its normal position, and has been described in the literature. Muscular bridges are also very common, as you can see here. You can see here there's a muscular bridge, large muscular bridge between the C6 and the C7 ventral ramus. Also, if you look carefully between the C5 and C6, there's another muscular bridge located between these. So they may indeed interfere with the spread of the local anesthetic within the interscalene groove. So, in conclusion, why a suit? Why would you want to do a sequential ultrasound imaging as opposed to just place the transducer and perform the injection? I think for safety and efficacy, it is very important. Accurately identifying the anatomical structures relevant for brachial plexus are vital, as I have illustrated to you, that intra-root splitting of the ventral ramus of C6 and C7 may result in inadvertent intraneural injection if you misidentify the two components of the C6 or the C7. Muscular bridges are very commonly identified, as I showed you, and some of our future research, ongoing research, is directed towards quantifying some of these muscular bridges. You can also identify anatomical variations that I illustrated to you. Various novel brachial plexus block techniques have been described in order to circumvent or avoid some of the complications that are common with interscalene brachial plexus block. And some of this is well known. Today, the superior trunk block is a very commonly performed technique to try and produce equally effective analgesia to an interscalene block, but produce lower incidence or minimize the incidence of phrenic nerve palsy or ipsilateral hemidiaphragmatic palsy. Also, anterior suprascapular nerve block have been described as a technique for analgesia for shoulder surgery, and we have more recently described selective trunk block, and we'll be discussing more about this very soon. May also have diagnostic application. You can see if you can accurately identify these various neural elements, then you can then say that yes, there is a neuroma of the C5 ventral ramus or a neuroma of the superior trunk. It may also be useful for dynamic ultrasound imaging when you are able to identify these structures and do dynamic effects of certain motor effects of function, muscular function, that are related to these neural elements. So it may have a role in the future to more accurately perform dynamic ultrasound imaging. With these few words, ladies and gentlemen, I'd like to thank you for your attention.